Yes, sir. Yes.
1 minute, sir. 1 minute.
Okay. Okay.
The goal is 10-15 minutes and leave more room for discussion, correct?
Yes, ma'am. Yes, ma'am.
So both of us 10-15 minutes?
Yes. Yes, sir.
Okay.
Varghese, sir, we are good to start, sir.
Good evening, everyone. Today is another day about the interesting topics that is related to the heart and lung transplant. Today we are bringing forward another interesting topics, that is about an interstitial lung disease. I think everybody hears about this topic day in and day out, especially in the transplant and pulmonology OPD. So the common questions that everybody asks is, sir, is there any treatment options that is available other than antifibrotics, or should I continue steroids, or when can I stop the oxygen and when will my suffering end? So we thought it's a very broad topic, and we have two experts with regard to this field from different parts of India. One is Dr. Sujeet K, sir. Sir is a consultant pulmonologist working in Mumbai hospital. As you know, sir has multiple publications with regards to idiopathic pulmonary fibrosis and many studies that is going on. So on to you, sir. As regard to the first topic, that is about the newer updates with regard to interstitial lung disease and especially IPF and the non-IPF related conditions.
Thank you, Vimi. I'll try and be short because I'm sure many people have heard talks on IPF, and I will try and restrict myself to, I'll just ensure there's no background noise. Just a moment, just. So can you hear me, Vimi? Well?
Yes, yes, it is.
Okay, I'm sharing my screen now. And I will tell you. Can you see the window clearly?
Yes, sir. You can, yes, sir. Now it's clear.
You can see my slides. Okay. So I thought we'll talk about 2024 because we are literally on the verge of the new year in a couple of weeks' time. And IPF management has really moved on in the last few years. How important is ILD in our practice is evident from this slide, where you can see that if you look at all causes of mortality, global mortality, it's very clear that ILD is really moving up that trend. And as you can see, ILD from the number 80th earlier as a cause of mortality has moved up to number 40. And I think this was data ending the middle of 2015. I think that would have gone up even further, probably 1 or 2 notches higher, because we know from Vimi's data and from data across India that it is the commonest cause for lung transplant referral these days. The tragedy actually of ILD and IPF especially is that around the same time, it took about 1 year for patients to actually confirm their diagnosis after they develop symptoms. That's half of the patients took about a year to reach a diagnosis, and another 1/5 of them didn't get a diagnosis for up to 1.5 to 2 years. So this is just not acceptable in a disease which has a survival of 3 to 5 years. If you're going to lose 1.5 to 2 years in just making a diagnosis, that's a lot of time lost in which you could do many things. And with current research in IPF, I think there's more and more exciting stuff along the way. Nothing magical as yet, but a lot of things happening there. So the diagnosis of IPF with the new ATS, CRS, JRS, and ALDT, new ILD and suspected IPF, do a detailed drug and environment. So for all of you young postgraduates who've tuned in, young chest physicians, don't forget history. you will be surprised how important and what information you get from the history that can completely change your management of an ILD. Family history, I would add to this slide, which is about 2 years old, because most of my talks have been on non-IPF ILD of late. And so this was a little older slide from the 18 guidelines, which were really the last detailed guidelines on diagnosis of IPF. Family history to me is equally important. One thing I would add to this slide is a drug history, environmental exposure, and a family history. And always get connective tissue disease serology done. Find a good lab to do this that understands the methodology well, and get a good rheumatologist whom you can always converse with. For now, do not measure serum biomarkers outside of a research protocol. I would not advise it, at least for now. The problem for many of you all tuning in is IPF and fibrotic HP, and often you have no cause identified for both. Fibrotic HP, if you identify an antigen allergen, then you're reasonably sure of the diagnosis, or the scan is typical, then you're fine. But if it is significantly fibrotic HP without inflammation, it becomes difficult. And so both these diseases progress. Both can be seen potentially in smokers, though HP a little less. Both can have traction bronchiectasis and honeycombing on CT. And in an advanced stage, both can have resting and exercise hypoxia. So IPF and fibrotic HP is really where you need to differentiate in India. And in favor of IPF would be an elderly male, ex-smoker, clubbed, with no autoimmune features or exposure to antigens, and a family history of IPF, especially not just ILD, would go in favor of IPF. And so IPF diagnosis in 2024 rests on three main areas: the scan, bronchoalveolar lavage, and biopsy. This is the fulcrum of diagnosis. And one slide on a good scan, it should be thin section, it should be volume images. For those of you who are listening in and you've got your CT radiologists whom you deal with, please ensure that good inspiratory breath hold is made, expiratory prone images, no contrast. There's a DVD, or you have online image transfer. And there are so many hospitals still in India which don't give a DVD with the CT, so many CT centers, and online image transfer where you get your scan done and you see it on your phone or your laptop within minutes. Even that is not there in the majority of hospitals still. So we need to get better here. And if you ask your CT radiologist, what I would do is, if your CT radiologist tells you he wants referrals from you, tell him, get this in order, and then you'll get my referrals. And this is if you're interested in ILD, this is what you will need. In acute exacerbations, you may need contrast to rule out pulmonary embolism, but otherwise, ILD scanning does not need contrast. Biopsy. Rajani is a far more experienced interventional pulmonologist than I am, but she's not talking on that subject today. Transbronchial, cryo, and surgical lung biopsy are the three types of biopsy we have. And when you look at our Indian data, just 7% of patients actually had a biopsy, which is really abysmally low. In such a situation, with 7% patients having a biopsy, most of our fibrotic HP patients, which is the majority of ILD, are diagnosed without a lung biopsy. That's why CT is so critical. Now, if you do have to go to a biopsy, the transbronchial lung biopsy has a 73 to 80% yield. The complications about 20%, not often serious. Surgical lung biopsy, a little more, but has a 90% yield. This is based on many studies in the last few years. 30-day mortality is, of course, a little higher with the surgical lung biopsy, and that goes up with age, low DLCO, poor patient selection criteria. And the cold eye study, which was one of the really good studies done in Australia, surgical lung biopsy added value to just 1 out of 10 patients, and therefore any meaningful change in decision was really done for just one. So 74% versus 78%. I think we're going to see less and less of VATS biopsies being done now for interstitial lung disease. But you have to know that the confidence levels of surgical lung biopsy are definitely a little higher. You get much more lung tissue. But there were only 6 patients in the entire coli study that had to be reclassified because of the surgical lung biopsy. Coming to conversations. Now, you have to talk to these patients, right? And that's what we wrote up in our paper. And this was early in March this year. You must explain the risk if you're going to do a biopsy to prove IPF or disprove IPF or prove anything else. You must explain to the patient if the decision is a close call. And the most important thing is management going to change? Otherwise, why are you doing a biopsy? If management is not going to change, you shouldn't be subjecting patients to procedures with risk. If it's unacceptable risk, you need to accept diagnostic uncertainty. And the final combined decision should be supported by you. So if the patient says he doesn't want a biopsy, you need to support him. You shouldn't say it is your way or the highway. You should tell him, okay, you understand that you don't want a biopsy. You understand the consequences of not doing a biopsy. And so I will support you and we will manage you in the best way possible. Sometimes you need to give time to your patient to decide. Monitoring is really lung function. I don't want to spend too many slides on that. Lung functions are not needed for diagnosis. They're needed for monitoring and prognostication. And the GAP model is a beautiful model to prognosticate patients, and I hope you all use that in your practices. You have a GAP index, and you have an even better index now called the DO-GAP index, which I will refer you to look at. And finally, treatments. What are the treatments for IPF that we have? The old approach, as Vimi mentioned when we talked, was corticosteroids. For years, we used corticosteroids, and for those of you who were in practice before 2010, there was nothing else. Till Selman came along in 2002 and said, hey, this is a non-inflammatory fibroproliferative disorder. There's no inflammation. Why are we giving steroids? This is idiopathic alveolar epithelial cell injury. Mesenchymal cells get converted to myofibroblasts. Where's the inflammation? Yet, despite Selman's research, steroids and azathioprine were used from 2002 till 2012. Nothing else we did except use these drugs. Why? Probably because we don't have such accurate tools to diagnose IPF like we have today, CT patterns especially. Also, those who had NSIP were responding, so we never knew if it was IPF or NSIP. Lack of other treatments. Only lung transplant was available in those days, so you had no other treatments, and almost no clinical trials between 2002 and 2012 on IPF. And then 2014, and you had these 2 great trials, pirfenidone, Ascend, and Impulse's nintedanib. And I'm not going to bore you with that data except tell you that the treatment effect was seen by week 13, that is 3 months, and that's why we repeat our lung functions earliest 3 months, where the mean decline was almost double for placebo as compared to pirfenidone. Likewise, in nintedanib, lower annual rate of decline in FVC. The Insights IPF registry, which was presented in ERS 4 years ago before the COVID pandemic, and I enjoyed this registry and learning into it. They had 290 patients never treated with antifibrotics and 298 treated. And we're talking of 2019, by which time these 2 drugs were approved. And you saw that patients who were never treated had a much lower 1 year and 2 year survival than those who were treated with an antifibrotic. Jürgen Baer published this data. And so you had a 37% lower risk of mortality, hazard ratio 0.63 for patients on an antifibrotic. And that, after the 2014 studies, really got us excited about antifibrotics. Yet we know patients get worse on an antifibrotic. We have evidence that pirfenidone can even benefit these patients who are progressing despite vital capacity dropping on the drug. Yet at 50% of patients at 5 years are still on pirfenidone, and that's really reassuring that patients are at least somewhat stabilized on an antifibrotic. The combination studies have not yet come out. At least with pirfenidone and nintedanib, there's InJourney. It's not powered. It wasn't powered sufficiently. 1/3 had to discontinue pirfenidone because they just couldn't handle the combined toxicity. It's not that they didn't tolerate pirfenidone earlier, but when you combined it with nintedanib, one of the drugs had to go off. 12-week study, but safety and tolerability was not too bad. How do you choose which antifibrotic? I guess number of tablets. And now you have higher and higher strengths. Till about a few years ago, we had pirfenidone only available as a 200 mg tablet. Today it's available as a 600 and an 801 mg tablet. And we are soon going to hopefully see a 1200 mg tablet, which will mean only 2 tablets to be taken for full dose. So it may not be the pill burden that is the determining factor in which antifibrotic you choose. Side effects, of course, can be photosensitivity for pirfenidone and largely diarrhea for nintedanib. Anticoagulation therapy, ongoing heart disease, slight tilt towards pirfenidone, though nintedanib can still be used. Cost, pirfenidone was much cheaper prior to the COVID pandemic. After the COVID pandemic, nintedanib became generic, and I would say cost is equal now. Smokers, you probably would prefer nintedanib because smokers metabolize pirfenidone better. It's rare to see an IPF patient who continues to smoke, though. And if you're planning major surgery, you may want to keep the patient on pirfenidone rather than nintedanib. And peanut soya allergy, and again, pirfenidone is probably preferred. Nintedanib is not the preferred drug. And prevention of AE-IPF, and we did the NNT study for that study with nintedanib, and we found that you need to treat 12 patients with IPF to prevent one acute exacerbation with nintedanib. So nintedanib, clearly a small advantage there. Let's continue. So as we go on, you had what's new and exciting, Talib gene, and I think I have 2 more minutes. Otherwise, I'll end in 15 minutes here. The Talib gene mutation positive study. Therefore, if once we get our genetics better and easier to order, NAC monotherapy could help for people with Talib gene mutation. The fundoplication study was negative, and pembrolizumab, which is a real tongue twister, the CTGF antibody is a positive study, so we may soon see that in the market. Whereas nintedanib with sildenafil for patients with more severe IPF and pulmonary hypertension was a negative study. A year and a half ago, the cyclophosphamide study called EXAFIP, where we used to use this in many years ago, and still till about a few years ago, for acute exacerbations, we'd add cyclophosphamide. Double-blind RCT showed increased mortality. So we would not recommend using cyclophosphamide anymore for acute exacerbations. And you can see here clearly the mortality was higher. So AE, IPF, no cyclophosphamide. AE, non-IPF, connective tissue disease, for sure you may want to consider it. Cleanup was a negative study. Pentraxin, as I said, praise pamrevlumab phase 2 data is interesting, and that's what probably we'll see in the market soon. What else do we have? And to summarize, really, treating IPF in 2024 is going to be an antifibrotic or a transplant as the patient gets worse. We're talking on the forum of a hospital that is pioneering lung transplant in India. And I think this is one of the best occasions to tell you that talk about it when you diagnose IPF, not when the patient is really sick. They need to start getting their brain together. They need to start thinking about the disease as it goes along. That's the only intervention that can reverse IPF for a patient. Of course, not the easiest intervention, but I think Yashoda has done a great job in containing costs in this space. Treating symptoms: oxygen, inhaled steroids, and morphine. Something we often don't use is morphine here. Great drug to treat symptoms, chronic breathlessness especially. Rajani is going to talk more about that. Rehab, palliative care, and counseling about transplant, even in the poorest patient. You sometimes don't know who is being supported by whom, and suddenly you'll find a poor patient who has a benefactor who will say, I will support that transplant. So don't forget about it. Counsel the patient about it, even if you're not referring them. And so symptom treatment is a little different from slowing disease progression. That's one thing we need to understand. The future is also going to focus on an early diagnosis of IPF. And as you can see here, what we want to do is really get a diagnosis much before we make it, because then we have a few more years for the patient. So when symptoms occur, it's another few years. Excuse me. However, if you diagnose it at the time of an interstitial lung abnormality or with some other method, like for instance CT can even do densitometric texture analysis and deep learning to identify IPF early. Genomic candidates exist, MUC5 polymorphisms, the telomere length, and a polygenic risk score which is being developed now. All of these can be interesting. And of course, peripheral biomarker candidates like the absolute monocyte count, growth differentiating factor 15, matrix metalloproteinase 7, and proteomic models. This is going to be the future of IPF in the next few years. Watch this space very closely. Communicating, I can't leave a lecture behind without saying how important it is. Rajani is going to talk about this, how we have to communicate better. What do they have? How we describe the interstitium better to our patients. What is inflamed and what could probably respond to anti-inflammatories, and what is a fibrotic interstitium which will not reverse. This communication is so critical to managing our patients with IPF better and telling them they have no inflammation, and that's why we are going to treat symptoms and we are going to slow fibrosis. So to conclude, in ILDs, good quality CT is extremely important. Transbronchial cryobiopsies are here to stay, and I'm so happy to see more than a dozen centers now in India actively doing cryobiopsy, which is great news for patients with ILD who need a better diagnosis. Antifibrotics are here to stay in IPF and non-IPF ILD. FVC, DLCO, and GAP are what you're going to use to monitor and prognosticate. But I think in the next few years, you'll have CT monitoring, genomics, and biomarkers for prognosticating as well. Do not forget palliative care and transplant referral. And my last slide is what Rajani is going to talk about. When do you learn swimming? Not when your ship is sinking, but on a good sunny day, when everything is good, that's the time to think about palliative care. Thank you very much.
Thank you, sir, for the extensive discussion about the interstitial lung disease and IPF and the new trials, and how to have a treatment approach from the beginning till the end, and what are the parameters to look for. We'll have the questions after the next speaker talk. So our next speaker is Dr. Rajani Bhat. So Madam is a consultant in interventional pulmonology and palliative care working in SPARSH Hospital, Bangalore. She's one of the pioneers who tells and explains a lot about how is the role of palliative care and what is the need for palliative care, especially from a pulmonology point of view. So over to you, ma'am, to explain about the role of palliative care, especially in interstitial lung disease. Ma'am, I think your sound is muted.
Are you able to hear me now?
Yes, now we are able to.
Okay, all right. And my slides are visible?
Yes.
Okay, great. Thank you, Sujeet. I cannot imagine anyone else who can give such a crisp yet comprehensive overview of interstitial lung diseases, right from the burden of disease to diagnosis to the evolution of treatment, and what is to come in 2024. That was really wonderful. Thanks a lot. So I'm here today to talk about the role of palliative care in interstitial lung diseases, and I'm really grateful that this topic was included in this discussion of interstitial lung diseases, especially in the context of people who are interested in offering all possible treatment modalities and benefits to our patients, including lung transplant. I thought we'll start with just understanding what is palliative care, because it is one of the most misunderstood fields of medicine. For a lot of people, the word palliative care immediately brings to mind terminal end-of-life care. But palliative care is something which actually is more to do with providing an extra layer of support to the patients who live with a life-limiting illness. It came about in the 1950s and 60s in the United Kingdom, evolved as a specialty. Initially was more about patients dealing with cancer and with chronic pain syndromes. Over time, we realized that 26% of the population of the world may die of a cancer, but the rest of us will have illnesses that affect many other end organs and lead to end organ failure. And these are different kinds of symptoms, and this is a different kind of distress that also needs support. Dame Cicely Saunders is considered the person who developed the concept of palliative care, is the original founder of the movement of palliative and hospice medicine. And she described a patient's suffering as total pain. Here, I want you to think of pain not as just a physical nociceptive stimulus kind of pain, but pain as distress, pain as suffering. And any patient who suffers from, who is experiencing a life-limiting illness, and we know that interstitial lung disease is a life-limiting illness, will experience some physical discomfort, will go through certain psychological distress and discomfort, as well as they come to terms with a pretty significant shift in their life and their way of life. There are social distresses, social pain, financial toxicity, and financial distress associated with the cost of diagnosis, cost of treatment, the loss of livelihood, and the loss of maybe dreams and relationships as well. And they go through some amount of spiritual distress as well. It's an existential distress. So I don't mean spiritual as in religious purely, but it's an existential crisis of, why did this happen to me? How did this happen to me? How? Why? All of these are questions that cause a lot of distress, keep people awake at nights, worsen their quality of life. So palliative medicine is a field of medicine which looks to address any health-related suffering that a patient is going through right from the point of diagnosis, during treatment, supports the patient at the end of life care, which is in the last 6 months or 1 year, supports the patient through the active dying process, and then continues to support the patient's family members or caregivers in the bereavement period. Nowadays, we have another layer that we have added on to palliative care, because with the era of transplants, there are patients who will suffer from severe illnesses, go through near-death experiences, and then sometimes come out of it with a lung transplant. But the issue is they've swapped one disease for another, because there still may be some symptom burden that some patients experience after transplant, certain limitations to life. So survivorship is also a period in which we offer palliative medicine support. Similarly, with cancers nowadays, with the advent of immunotherapy and newer targeted therapies, patients survive longer, living with disease, living with a greater burden of disease. So survivorship is also something that we support in palliative care. Sujeet mentioned something about communication, and it's such an important thing, because what ends up happening is that we are very comfortable as pulmonologists in coping with or facing questions from patients about their radiological investigations, about their biopsies, about the side effects of medications and the percentages and risk factors and all of these things. But we get a little uncomfortable when it comes to difficult questions about mortality, about maybe facing up to the fact that the patient's quality of life is going to worsen, they're not going to get better, and that they may be not have more than 6 months to 1 year to live. So these are times when we actually need to engage deeper with our listening skills with the patient, to understand what is the patient really trying to get from us, more than just about the disease. They're trying to understand what their life is going to be like, and how can they make more meaning out of something which has so profoundly affected their lives. So patients with interstitial lung disease, suffer from a lot of extensive symptoms. The most common ones that we see and address are going to be the breathlessness, the severe cough, the fatigue, and the reduced exercise tolerance. But this was actually a comparison that we did in a review earlier this year. And we looked at it to understand how many different symptoms that patients with interstitial lung disease experience. And how is that when you compare it to patients with severe diseases like cancer, AIDS, congestive heart failure, kidney failure, and things like that. And then you realize that patients with progressive fibrosing ILD experience such a multitude of symptoms: pain, depression, anxiety, fatigue, breathlessness, insomnia, nausea, diarrhea. This is just a few. I've just listed out the few that we could find comparatives with other life-limiting illnesses. And if we say that patients with cancer, patients with AIDS, HIV, will benefit from palliative care, it goes to say then, with such a high symptom burden, that patients with ILD will also benefit from early intervention with palliative medicine. My life took a significant turn towards exploring the study of palliative medicine, delving deeper into it with this paper in 2014-15. And this was a paper that came out of King's College London, Dame Cicely Saunders Institute of Palliative Medicine, and it looked at the effect of an integrated palliative and respiratory care service for patients with advanced disease, advanced and refractory breathlessness. So this is actually a mixed group. It's a small study. The number of patients on each arm is about 42 to 45, and these are patients who are on oxygen. It's a mixed group of patients with COPD, interstitial lung disease, as well as cancer. What they found was that in comparison to patients who have standard of care, if you added on the extra layer of breathlessness support service, which is a palliative medicine service, these patients had reduced hospitalizations, reduced ER visits, and they also had a survival benefit. So this was a very important finding, and this is 2014. We are 9 years later. As Sujeet mentioned, we're entering 2024. Along with the advances in pharmacotherapy, it's important to note that there are many other modalities of treatment that we can offer patients, which can help them in improving survival with interstitial lung disease. Another landmark paper that came out just a few years ago, I think this is 2019, was this comprehensive paper which was called Living Well with Interstitial Lung Disease. And in this, they looked at what are the needs of patients. And in this, you see, number one is adequate information. So how do we communicate with patients? Again, going back to Sujeet's point about understanding their illness, meeting them where they are. And in this is about adequate information, going over it repeatedly, using visual aids, using simple language that the patient can understand. One of the best ways of explanation I heard was from one of the senior ILD nurses in the UK. And she describes it, I used to describe lungs as like soap bubbles, detergent foam, something that's fine. And she describes the process of how ILD happens in the way that you can describe it with a sponge scrubber that you use to wash your utensils. So there's one side which is yellow spongy, and the other side is the rough, wiry, green, brown side, which is for scrubbing out more, stubborn stains. So she describes it as going from a process where your soap bubbles, then becoming the foam which you use to wipe off grease, and then going on to the hard, fibrous stuff. So these are things that are vivid things, images that patients can then understand as to what's happening with their lungs. So timely diagnosis, again, is something which causes distress to patients. Sujeet spoke about the delay in diagnosis. Having the family involved in understanding what the treatment is going to do for them, engaging them in early pulmonary rehabilitation, and trying to optimize the quality of life and functionality of the patient as much as possible. So this was presented as the ABCDE of interstitial lung disease care, where we assess the patient's needs and values, make them a partner, as well as bring in the caregivers as partners in care, educate them as much as possible, connect them to people, other patients whom they can connect with, help them in adopting healthier habits, stopping smoking, for example. And then taking the disease-modifying treatments, making sure symptoms are addressed, comorbidities are addressed, and making sure that timely discussions happen as the disease progresses about whether they need transplant, or if they are not candidates for transplant, then looking at options for relieving breathlessness, refractory breathlessness. Breathlessness is the most distressing symptom that patients with ILD face. And this is a model that I use extensively. It's called the breathing, thinking, functioning model. It came out of Professor Anna Spathis's work and Professor Sarah Booth's work at Cambridge. And really, it looks at ineffective breathing and the patterns of breathing that come in, the kind of thoughts in terms of thinking that patients with ILD experience. When we think of the worst possible pain, we think that we might pass out with the worst possible pain. When you experience the worst possible breathlessness, it comes with this threat to life. I feel I'm going to die. And I end up having an exacerbation, which may take me to the emergency room, which might cost me a lot of money, which means I might go to the ICU. I'm in an alien environment, which is very scary. So the next time I experience another episode where my breathlessness is worsening, it directly takes me back to that panic, that moment when I thought I might die and not make it. So how do we learn to break those patterns of thinking and say, I have the tools to handle my breathlessness. I know I can get better. I know I can manage this. And functioning. We know that with loss of lung function, patients start moving less and less, and then they become weaker and weaker. There's deconditioning. So how do we help them understand that breathlessness will not go away? We learn to live with breathlessness. We learn mastery of breathlessness, and we learn to remain as functional and as mobile as possible with the breathlessness. So in that, pulmonary rehabilitation and breathing techniques and learning ways of breaking the vicious cycle of anxiety and breathlessness is what comes into play. So when should we think of, and all of these are things that we can do as pulmonologists. So there is some amount of palliative medicine which is offered as primary palliative care by the main doctor taking care of the patient. When do we need specialist referrals to palliative care? When should you involve a palliative medicine professional? So the Danish Respiratory Society recently put out some thoughts about what they suggested would help. And this is actually quite in line with the Indian Chest Society's recommendations and guidelines as well. So when you have recurrent hospitalizations, when the saturation is low, it's all persistently below 88-85%, when the FVC is less than 50% and it's dropping, when the patient's 6-minute walk distance is reduced to less than 212 meters. Now, this means that the patient's quality of life is very limited. They're housebound, literally. And the presence of pulmonary hypertension or new comorbidities coming in. This is a pretty extensive list, and it's a broader referral point guideline. In our setup, where we may not have access to so many palliative medicine specialists, a more appropriate screening tool could be the value of the surprise question. So the surprise question is, if I ask myself as a practicing pulmonologist, would I be surprised if this patient did not survive beyond 1 year? And this has a sensitivity of nearly 70% and a specificity of almost 85% to predict that yes, this patient's survival would be less than 1 year, which means that they would benefit from integrated palliative care services or at least a consultation to address their quality of life. How do we improve their quality of life? At this point, when the surprise question comes about, it's important to start having conversations with the patient and the caregivers about what would they want. Is this patient, and we need to know, is this patient already someone who you've had conversations about transplant with, or is this a patient who is not a candidate for transplant and is looking at conservative management? Because we know that mechanical ventilation outcomes for patients with interstitial lung disease, any form of interstitial lung disease, are pretty bad. So, and there's data on this, but most progressive fibrosing ILDs, if you have a severe acute exacerbation, which means that you are now going to be intubated, even if you come out of that episode, from that point on, there is a marked decline that happens in the patient's quality of life and their survival as well. So it's important that at this point, we start having conversations. What are these conversations that we need to have? It's about helping them accept and understand that at this point, our main focus is symptom management. offering them psychosocial support, offering them help with decision making. So what happens if you go to the ICU? What happens if you're on a ventilator? What is CPR? What will happen even if I survive a CPR? If I realize that's not what I want, then what else do I need to do? I need to manage my finances. I need to take care of certain personal responsibilities, helping them in coming to terms with what their disease is going to be and telling them that they will be supported even when the symptoms are worsening and they are limited in their mobility. This point, it's also very important to speak about opioids and benzodiazepines. When a patient has a disease that is not going to be treatable, curable, and is approaching the end of life and is having severe refractory breathlessness, opioids are essential. And at this, it is important that we learn to be comfortable with prescribing opioids. There are wonderful articles that I can refer you to. We've used this even during the COVID pandemic. We made this widely available because when you have nothing else to offer, at least you can offer relief of symptoms. Morphine has been used for a long time for relief of breathlessness. We use it in immediate release morphine formulations. Orally, it can be used as I start off with half of a 10 milligram tablet, that's 5 milligram every 6 hours. So it's divided doses, 10 to 30 milligrams. I've rarely had to cross 30 milligrams only for breathlessness. If the patient has other pain symptoms as well, maybe the dose goes higher, but you really don't need much more than that for breathlessness. Always give a Powell regimen. Our patients with ILD often have constipation as well. So the hand that writes the morphine also writes the Powell regimen to make sure that they're not distressed with constipation. This is a review that we put together in April of 2023, and I've asked the Yashoda team to share it with everyone. This has a more comprehensive listing of all the different measures. So the evidence to support early palliative care in interstitial lung disease and how that improves patient and caregivers' quality of life, as well as the medications and the evidence behind the use of those medicines. And I thank you once again for this opportunity to share. Thank you. I'm sorry if I overshot the time. Vimi, we're not able to hear you.
Thank you, ma'am, for the extensive discussion about the palliative care. We still have 15 minutes more, ma'am. So we'll take just one or two questions with regard to this about topic. I'm actually very surprised to see about actually even personally also we had when our grandmother had a end stage lung disease, and I personally know how palliative care has changed our family's perspective as a whole, because I think more than the disease progression, it's all about symptomatic relief what patients get at the end of the day, and it really helped the my grandmother and many other stories which I have seen, especially with related to transplant, etc. So coming back to the broader perspective of interstitial lung disease, to Dr. Sujeet K, sir, it's a usual question that arises to many pulmonologists. What is an ILD exacerbation? So everybody thinks ILD exacerbation is only infection, you give more steroids. But coming back to scientifically, how do you tell that somebody has an ILD exacerbation?
So basically, Vimi, any patient that has a significant increase in their symptoms from baseline would be thought to be exacerbating. And I know the term has no clear definition, if you ask me, but it does, you can have mild exacerbations, which come into the clinic and may just need an antibiotic and they're done with it. And then you can have moderate exacerbations, which I would probably call, breathlessness, a little drop in saturation. They're disinclined to come to the hospital, and you may want to give a short course of prednisolone, send their sputum out, give them an antibiotic, maybe an antiviral as well, if they have come early enough. And then you have the severe exacerbation, which is, that lands you up in the hospital. And I think that's the exacerbation you want to prevent, because that's the one that really hits the patient's lung badly. And you can see if you look at the decline in lung function over years in any interstitial lung disease, and especially IPF, that decline goes down, that graph goes down further and never comes back to its baseline. It's always lower than what it was. And this is a very important point that we use for counseling patients, Vimi. I think, you asked about exacerbation and why is that important is that, and Rajani would probably also testify to this, that when the patient's in the ICU with an exacerbation, the relatives have a few questions for you. 3 of them I can tell you straight away. One is, will he be cured of his illness if they've never been educated about the ILD? So you have to start from scratch then. But if you have done that well in the clinic, you don't need to. So if it's my old patient, that part is taken care of. But still somebody will ask me, can he be cured? You'll have another relative who suddenly arrives on the scene asking about that. The second question that they would ask is, can we just get him back to what he was, right? And that is something that we may not be able to achieve because an exacerbation hits you so badly that your baseline shifts down. And so we got to tell them that, look, if your quality of life was at an X level, you're going to be X minus 1 or minus 2 now. And that's hard for them to really understand. Of course, the third question is the whole set of questions that Rajani spoke about as to, is this exacerbation going to land them up on an invasive ventilator? And how long are they going to spend in the ICU? And today we have so many ways, Vimi, of extending patients' lives. I mean, from, just simple oxygen to HFNC to NIV. These are very useful for transplant programs where you're given that window to work with. But sometimes if the patient is not going for transplant, then you wonder what you're doing, right? I mean, you're sitting with a patient who's so sick in the ICU. And if he's on HFNC, you can't even give that at home. So how long are you going to give HFNC? So the exacerbation throws up so many things. It's fascinating how communication goes during an exacerbation, but it's a lot easier if you do a lot of pre-counseling in the clinic when you've seen the patient first time. And if the patient comes for the first time to you in an exacerbation, it's a nightmare, at least for me.
Yeah.
Yes. Madam, you want to have...
I'm glad you brought up the issue of HFNC, Sujeet, with exacerbations, because I think increasingly we are working towards convincing more and more hospital administrations to allow for HFNC to be used even in the ward setting rather than only in the ICU setting.
Right.
Because with the ILD patients, HFNC is of great value in an exacerbation.
Yes.
Even if these are patients who have decided that they do not want to go for invasive modalities, or you're advising them that this is moving towards comfort care. Say we're not able to wean them off the high FiO2 and flows of HFNC. We can bring them to the ward and titrate up the morphine and then slowly wean them off. But there are actually quality of death surveys, bereavement studies that are done on caregivers of patients with ILD. And they always say that the caregiver and the people we leave behind, their trauma is much less if it is HFNC as opposed to mechanical ventilation or NIV, because the patient is at least able to, just a little water, a little food, converse with the family. So that trauma is reduced with HFNC.
Absolutely.
Sir, other common thing what patients and the other people have in mind, or what they come to the OPD is whether I should take vaccination with this increased breathlessness and will I land more in trouble? So what is your take on vaccination, sir? Especially with the patients with end-stage lung disease?
Well, I'll my quick take on that is, Vimi, that they should get it. There's no way they should not get vaccination unless they've had serious adverse reactions to a vaccine earlier. I think even the egg allergy part is now almost out of the way because there's hardly any egg protein being used now in the newer vaccines. So the vaccines have become safer. No question about it. They're very protective. And you're going to see and pneumococcal, I would say influenza, the southern hemisphere strain for India, quadrivalent strain, and herpes zoster. I think these three vaccines for sure. And Tdap once in 10 years. I think that should cover the vaccines. Now we're going to have dengue, malaria, and someone could argue. I mean, they'll all be coming up soon. I think there's very good data coming on these vaccines. Chikungunya, especially, I think that's coming to India soon. So, people are going to ask us questions, and so I think we had a patient support group meeting, which we just started last weekend. Commonest question among patients was, "What vaccines should I take?" So I think
I would
yeah,
agree with you, Sujeet, completely. Because even from the palliative care perspective, if I look at it, you
yeah,
mentioned some of the other illnesses, right? Like
yeah,
chikungunya, dengue,
sure.
malaria, and the others which are coming up. These are on the horizon for us. Anything that will worsen the quality of life for the patient with that entire laundry list of symptoms. As
Right.
long as we have vaccines that are safe enough and efficacious, I would think that it is worthwhile to offer. The first list that I think in practice, I've rarely had difficulties in convincing patients about vaccinations with respect to breathlessness.
Right.
That's not a problem because they all realize that um, a hospitalization is far more problematic with a severe respiratory.
Why I asked Madam this specific question is we have many CTD ILDs who are on very high oxygen require, who's already on multiple steroids and immunosuppressants, who we probably plan or list for transplant, and we do the regular list of vaccination. And over the time we see that after vaccination they get frequent admission, so nobody's sure about is it directly related, not related. And finally one more admission from a transplant perspective and on HFNC or on NIV is a greater challenge. So it's not directly related, but it's always comes in coincidence with this vaccination timing and exacerbation, which always alert the physician or a pulmonologist regard to this topic.
I think it's worth exploring, but my off the top of my head take on it would be true and unrelated. So I don't think we can prove causality yet. Vaccination and exacerbation. Sujeet, are you aware of anything which shows a direct correlation of vaccination with exacerbations? Not that
Not really. I think that could be just, probably Vimi
It's like
sees
the
too many
state of the
patients.
disease
Yeah.
at that point when they are listed for transplant. They would have had it even without.
Yeah. I think Vimi's uh, patient demographic is probably full of very sick patients, so they'll blame anything for their illness, from a vaccine to emotional stress to whatever, Vimi. And, we have to deal with all that. There's no data to suggest that vaccines really push them across. But vaccines have side effects, Vimi.
Yeah.
There's no question about it. Okay. I think we're not hearing too much about that. One of the reasons may be that doesn't get as much prominence in media and the journals as vaccine efficacy, which for sure outperforms vaccine side effects, right? But I think we're going to see more and more vaccine side effects in the future for the simple reason that more and more people are going to get vaccinated. It's as simple as that. So we have more people vaccinated, 1 in a million chances become more than 1 in a million for sure.
And I think the other part of it is memory biases.
Yes.
So vaccines are very significant moments in a patient's life. And if you think of it, even when I'm counseling the patient, I'm telling them about this is a vaccine you need to take every year. This is a vaccine you take every so many years. So I'm actually helping them to imprint it in their memory when I speak, like when I give them the importance of the vaccine. So that becomes a landmark event. Then anything that happens after that, you observe much more. And the correlation happens because of that. I'm not really sure it's causation.
And we have one question from audience. She's talking. She wants to know more about what are the breathing techniques used. Yes, ma'am.
So I think the most important underused modality for breathlessness is a handheld fan. So if there's one message that I think everyone should take home, is the use of a simple handheld fan. So you get these tiny little things on any web, you can buy it online, or even just use the old-fashioned handheld fan. This area of the face near the nose and mouth, you take a wet cloth, moisten your face, and use a handheld fan when you're breathless. So the immediate impact of that is a decrease in the perception of the dyspnea. So the breathlessness reduces, the discomfort, the sensation of breathlessness reduces immediately. So using a handheld fan. In terms of breathing techniques, the standard techniques that you're familiar with, pursed lip breathing, abdominal breathing. The other thing that we use is breathing in a rectangle, where you're asking them to just focus on breathing out. So if you see architecturally, most of our doors, windows, there's something or the other in a room always that will be in the shape of a rectangle. So it allows us, when we're losing our mind with breathlessness, to center on something and say, breathe out. So you go, like, so you just teach them how to do that when they are well, so they can do it when they have an episode of breathlessness. One more important thing that I tell them to do is pacing in their homes. So I ask them to map out from the bed to the bathroom, how many steps do they take? So at what point do they pause, do some pursed lip breathing, recover from their breathlessness, and then take a few more steps. So you learn to plan your walks, whether it is walking to the dining table, walking to the bathroom, learn to listen to your body signals earlier. So these would be the main breathing techniques that we use, about using more efficient breathing, the pursed lip breathing, belly breathing, pacing, positioning, and the fan. Those would be what I want most people to get comfortable with. I used to do home visits, and I find them really, really useful, because very often it's just rearranging furniture so that the patient's line of walking for two different places is as unobstructed as possible. There's no obstacles in the way, and they start walking more. The minute they start walking more, they manage their breathlessness better. So I can even do things like putting pointers on the wall, like putting a picture on the wall, keeping something right opposite where they sit, which is a calming image. Using any of these things can help with the breathlessness management. So if you have an episode of breathlessness, if the image of a cool, calm mountain or a seashore makes you feel good, put that big photograph right opposite you. So that allows you to immediately start working on your breathing techniques and recover. And also tell the family member how to help them with this, right? Loose clothing, positioning, all of that.
I think the handheld fan is a very important, and it really gives a very much symptomatic relief. Today we have 2-3 patients on awake ECMOs who is waiting for transplant. So the one question what they always tell during our rounds is, sir, kindly switch off the AC and give us a small fan on the corner, so that it gives a relief. So I think it plays.
Most hospitals do not have fans. They have air conditioning, and you can't open many windows. So all respiratory patients who I admit in our wards always have a fan, a table fan in their room, a small table fan, which they can choose to either direct at their face or just around near them. So they need to sense air movement always.
Yes.
In fact, it even increases your threshold to prescribe oxygen to some patients. So there's data on that prescribing a handheld battery-operated fan for patients who desaturate is better, because it just calms them down, makes them breathe slower, and they need less ambulatory oxygen.
Yeah. So the most underutilized breathing tool is a handheld fan, and more people prescribe it.
Ma'am, other important doubt what everybody, all patient perspective has is, how does oxygen therapy really helps in the initial and towards the progressive phase of interstitial lung disease? So everybody is worried about when I use oxygen early, I'll be using oxygen throughout my life. So what is your take, or what is your advice to them?
So if it's really about correlating so one is oxygen will help you if there is significant desaturation when you're exercising, right? So if the patient walks and they desaturate, then having oxygen helps them maintain their mobility. So it helps them with the functioning part of it. That will help them long term. The longer they can keep walking and mobile, it's important. So oxygen helps with that. Patients who have pulmonary hypertension, we know that oxygen helps them as well with helping reduce the pulmonary hypertension that's coming as secondary pulmonary hypertension with this. That being said, I usually want patients to start focusing more on how they are feeling and their perception of breathlessness, because our patients with ILD are going to get progressively more hypoxic. So each patient, it's not that for every patient, I want the saturation to be 90%. There are going to be patients who are at a baseline on their oxygen, on 4 liters, 80% saturation, and they are okay. They are okay even to walk to the bathroom on their own. They know their limit, that I get dizzy when my saturation falls below 65%. So you'll tell them, use your techniques, increase the flow. So what I tell them to do is, if you need to go to the bathroom, if you're on 2 liters as a maintenance, hike it up to 4 to 5 liters for a couple of minutes, walk with your pacing, go to the bathroom, do your business, come back, again be at 4 to 5 liters for the next 10-15 minutes, bring it down again. So they really learn to tune into how they are feeling, their perception of breathlessness, dizziness, all the other symptoms, rather than obsessing about watching a pulse oximeter and how much is the flow. It will be different for each patient. And that's why when we're doing the pulmonary rehabilitation as well, we tell the therapists to keep a watch on the pulse oximeter. We tell the patient not to look at that time at the pulse oximeter. We'll say, we will tell you, you're doing good, you keep exercising. We'll tell you when you need to stop and rest.
Okay, that's a great advice. Otherwise, patient will be looking on to the pulse oximeter and finally getting stressed about it. I think we have answered all the questions in chat box. Finally, sir, just finally your advice to the patients in one sentence with regard to the interstitial lung disease from both of you. To Sujeet Ranjan, sir, what is your take to the patient, sir, from in one sentence?
So I think in one sentence, I would say these patients should be diagnosed early and counseled about drugs to slow the progression, as well as focus on symptom management and be counseled about transplant. If I had to put it in one sentence, you have to do all that. Unfortunately, it's a long sentence, but all this should be done: an early diagnosis, appropriate antifibrotic, symptom management, and counsel for transplant. All this should be done in the first 2 consults itself.
Okay.
I think for me, I'm going to speak from the palliative medicine perspective, from diagnosis to transplant survivorship or end of life care. It's going to be about so it's trying to figure out what matters to you most. So there's a very famous quote in palliative medicine saying, it is not what is the matter with the patient, it is what matters to the patient. Right? So trying to maintain what matters to you in terms of functioning, in terms of your roles that you play in your family life, right? You could be father, mother, son, daughter, wife, sister, whatever, and you could have a professional role. To know what your priorities are and ask your doctors to help you meet those priorities throughout the course of disease. So the symptom control is towards me as a person, not as a patient of ILD. Right? That would be the focus, that each patient should say, this is what I am hoping for, wanting for, this is what I'm afraid of, this is what I would like to keep doing, and can you help me get there?
Yeah. So thanks to both of you for giving an elaborate discussion about this topic. It was very interesting that many of our patients also joined, and we were also able to address many questions from a patient point of view also. So thanks to both of you. Thank you everyone for joining. Good night.
Oh, I wasn't aware that we had patients listening in.
Yes.
And I hope it was useful to our patients as well. We're very happy to share anything that can help in the journey of ILD. Thanks.
Thank you. Thank you.
Thank you. Thank you.